Hi, I'm Dr. Ann Kellams. I am a professor of pediatrics and director of the UVA Breastfeeding Medicine program at the University of Virginia School of Medicine in Charlottesville, Virginia, in the USA. I'm going to say a few words about tongue tie because it's something that we get asked about all the time. I think it's a myth that there's no such thing as tongue tie. And when I was training in the mid-90s, that's what I was taught as a resident on the newborn service. You'd see a baby with a really very obvious tongue tie, and I was taught we don't do anything about that. If you look, though, at who was breastfeeding then, that was near around the time of the lowest breastfeeding rates in the United States. So it was very common. In fact, we got down a little bit before that, in the decade before that, to like 1 in 5 women even trying breastfeeding. So if you think about it, people would try it, and it either went well or it didn't, and it was no big deal. They would just start formula. So I think that's partly the reason that I was taught that. There's data to show that midwives used to keep a longer fingernail and actually clip it in the delivery room. And there's also instruments for circumcision that were turned around and had a grooved retractor, and those tongue ties were clipped. So if you've never heard of it or you're wondering why it's done, that's just to say that there was a period of time where it wasn't really trendy to think about it or do anything about it. But the fact is that every now and then there is a tight lingual frenulum, and depending on the baby's mouth shape, the size of their tongue, how far their chin goes out, and then the breast, how soft or firm the tissue is, how mobile the nipple is, whether or not it's stretchy or very, very soft, how far it's sticking out. You can imagine there might be a scenario where the tongue doesn't stick out as much and can't hit the right place on the nipple. So for that reason, we do recommend checking every newborn with just your pinky finger and kind of sliding under the tongue and really assessing, can you get, about 1 centimeter all the way from one corner of the mouth to the other without any resistance? Is there a little speed bump that you feel? And then again, is there an obstacle where you actually have to remove your finger and go to the other side? And then we look at the baby's tongue. Is it heart-shaped? Is the baby able to elevate their tongue up towards the palate, for example, when they're crying? Or is it getting blanched and pulled and staying very far down? Are they able to extend it past the bottom lip? So we're looking at sort of mobility and that sort of thing. And then we're working on latch. And so if the baby is not able to sustain a latch, or the mother is having nipple pain despite all of the positioning and attachment help that you can imagine, or if there is milk there clearly, and this would usually be after lactogenesis stage 2, and the baby is having trouble getting it out. So they're not transferring as effectively despite all of the possible breastfeeding interventions. So then and only then would we consider clipping it. I have what I call my rules of tongue, and that's to say there's no data to support clipping a lip tie for the purposes of breastfeeding for any reason. And I am suspicious of people referring to tongue ties in different ways, such as this is a posterior, this is an anterior, as we don't have any anatomic data to support a real distinction. I do recommend always checking and looking for movement like we talked about. And then I'm wary, especially in the United States, of any of these procedures that are cash only with providers, because insurance does cover the cost in the United States of a tongue clipping or tongue tie clipping. I am suspicious of any procedures where there's directions to the family about they need to drive to a different state or a different city or 4 or 5 hours away for this one particular person to do it. I am suspicious if there has not been a lactation or breastfeeding medicine professional involved in the assessment of the feeding prior to the procedure. And then based on my own personal experience and what's coming out in the statements from the various organizations, laser procedures, I have seen more complications with those, and we're more concerned about, the burn implications. We worry about oral aversion, whereas a nice scissor frenotomy is a very quick procedure. There's also no data to support special therapy or care or stretching or wound massage after the procedure. And particularly for newborns, the only indication for doing this would be because of feeding problems that persist beyond the regular breastfeeding management strategies. And so therefore, we would suggest that the newborns are eating all the time and using their tongue all the time, and they tend to do very, very well with no further intervention. I've listed here for you some of my most trusted tongue tie resources, including, first and foremost, the Academy of Breastfeeding Medicine clinical protocol.